shall we start?
Yes, sure.
Okay, are you ready? All right. Okay, I'll start first. Okay. Assalamualaikum warahmatullahi wabarakatuh, everyone. Thank you very much for joining us today. A very good morning, and welcome to our Fast Talk number 4 for 2021. So this event actually is jointly organized by RMC Kuantan and also the Library IIUM Kuantan. Okay, and this morning we are very honored to have our speakers today, Dr. Siti Roshaidai binti Mohd Arifin, and she will talk on improving in Southeast Asia research collaboration. So before we start, our today, Dr. Siti Roshaidai binti Mohd Arifin. She is an professor in Kulliyyah and previously she obtained her degree in Malaysia, followed by master in University Malaya and also PhD from Siti Affairs and Industrial Linkage of Kuantan, and she is a 30 researcher from IIUM. So we are very proud of her, and she had a lot of awards. For example, the highest citation index and the top 20 contributors from nursing, and the list goes on. And Dr. Siti, basically, her field is more on maternal and childcare, and she had a lot of collaboration with UK, Indonesia, and the other industry. Published a lot of paper on maternal mental health and also the childcare. Without further ado, I would like to invite our speakers today, Dr. Siti Roshaidai, to deliver her topics. Dr. Siti, the screen is yours. Thank you.
Thank you so much, Dr. Widya. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Assalamualaikum warahmatullahi, and a very good morning to all of you. Thank you so much, RMC and Dr. Widya, for the invitation and a very sweet introduction. My name is Roshaidai, and I'm from Kulliyyah of Nursing. It is my great pleasure today to share with you some of my work on maternal mental health. I have attended an international conference last year and found this statement by the keynote speaker, and it is quite interesting. She said that in much of the world, the most dangerous thing a woman can do is become pregnant. Some may disagree, I believe, but perhaps we can agree that the process and outcomes of the pregnancy does not always come with positive things only. Of course, the best outcome of the pregnancy is the baby, but there are other changes, complications that come with the adorable baby, such as the physical and mental health changes that the mother might have throughout pregnancy and after childbirth. If we have a look at this figure, we can understand that antenatal period begins with the conception and fertilization and end with birth of the baby or the delivery process. The period after the delivery until 1 year after childbirth is known as postpartum or postnatal. The period from antenatal until postnatal are commonly called as perinatal period. And the perinatal period is well-known period of extreme changes, either physically or emotionally for some women. And those changes that make the woman at high risk of developing some types or some level of mental health disorders during their pregnancy and postnatal period. Other factors that can contribute to high risk of contracting mental health disorders throughout perinatal period are poor social support, low socio-economic status, first-time mothers, single mothers, mothers who have had health problems during their pregnancy, and mothers with unplanned pregnancy. Maternal mental health disorders include a range of disorders and symptoms, started from baby blues until postpartum post-traumatic stress disorder. But the most common types of the disorders are perinatal depression and anxiety, which can occur either during antenatal or postnatal period. The symptoms of perinatal depression include weight changes, lack of concentration, feeling guilty, inability to enjoy or to have fun, and feeling of helplessness. The women may also feeling tired or loss of energy, having sleep disturbance, getting easily irritated or sensitive, become less active, and might have pain for no apparent reason. In some instances, the woman may react negatively towards the child or the baby. And at its worst, perinatal depression may lead to suicide. Therefore, maternal mental health disorders require treatment, which usually consists of counseling and possibly medication. On the other hand, anxiety is a feeling of pressure, uneasy thoughts, and physical changes like an increase in blood pressure. So the individual with anxiety may experience physical symptoms such as sweating, trembling, dizziness, or a rapid heartbeat. In low and middle income countries, as many as 1 in 5 new mothers experience some type of maternal mental health disorders, mainly depression and anxiety. However, these disorders frequently go unnoticed and untreated, often with tragic and long-term consequences for both mother and child. Without the right kind of support and treatment, perinatal depression and anxiety can have long-term negative effects on the mother's and the child's health and well-being. We know that Southeast Asia comprises countries that are highly diverse in terms of ethnicity, language, culture, and economic status, with several countries categorized as lower middle and lowest income categories. In this region, maternal mental health disorders is poorly understood and may be considered socially and culturally unacceptable, with affected women and families experiencing stigma and blame. There is also inequity of access to skilled mental health care professionals and lack of care guidance appropriate to maternal mental health. So this means maternal mental health disorders is largely under-recognized and under-treated within this region. I have been working in the area of maternal mental health since 11 years ago. I studied on postnatal depression, unplanned pregnancy, and sense of personal control during childbirth in my master's degree, and this was a quantitative study. I then continued to study this area using the qualitative approach during my PhD, whereby I explore the healthcare professionals and the women experience in managing postnatal depression in Malaysia. It is actually the findings and recommendations from my PhD study that had partly shaped the projects that I'm currently working on. For instance, findings of my PhD project has led to two recommendations. The first recommendation was there should be a revision of the existing screening instruments or screening tools to assess symptoms of postnatal mental disorders among Malaysian women. And upon its revision, a study to validate the new instrument is required. The second recommendation was future studies should consider a broader spectrum of maternal mental health disorders and not limited to the concept of postnatal depression only. To further study on the area of maternal mental health, we are currently running 3 relevant collaborative research projects. The first project was mainly led by Professor Margaret Maxwell from University of Stirling, Scotland. This is an international collaboration between 8 universities from 5 countries, which are UK, Thailand, Myanmar, Indonesia, and Malaysia. We are currently working on completing the signature for MOA. Of course, working with many universities is not an easy journey, I would say. It gives us some level of challenges, especially in getting the signature. Alhamdulillah, for IIUM, we received good support from our Office of Legal Advisor, OLA, and our rector had signed the agreement 2 months ago. The project actually covers 3 areas. The first is to further develop and consolidate our research network, our existing research network known as CPMHRN, that will bring together multidisciplinary experts from different fields of research, clinical practice, and also community development. We also include women's organizations, women with experience of maternal mental health disorders. We believe that this approach is important in order to co-produce a context relevant research agenda to understand and also to improve maternal mental health in the region. The second area is to test the methods for digitally capturing a range of women's experience from across participating countries that I mentioned just now. We propose to have a form of digital stories from the women. The stories can be either the recorded voice or recorded video. We expect that these digital stories ultimately shed light on different cultural experiences of maternal mental health disorders and their preferences of care and interventions. We also expect that the use of digital stories will provide a resource of future awareness-raising interventions and also materials. The third area of this project is to conduct a literature review on the prevalence of common maternal mental health disorders in Southeast Asia, conducted using translated version of tools that have been validated in developed countries, and also to evaluate the psychometric properties of these translated tools. So now our team in the UK is currently leading the systematic review, and team in Thailand, Malaysia, and Indonesia are currently in the phase of collecting the patients' experiences. Prior to the project secured, we have actually established what we call Southeast Asian Perinatal Mental Health Research Network, or CPMHRN. This network is currently involving members from UK, Myanmar, Indonesia, and Thailand, and also Malaysia, and includes researchers, clinicians, and a Ministry of Health in the region to develop a long-term research program, of course, in the area of maternal mental health. So under the network, Malaysia will be the hub or the center, or with collaboration from researchers in other countries, as I mentioned just now. The second project on maternal mental health that we are currently working on is designing an assessment tool for postnatal mental disorders. This is a national collaborative research project between IIUM, UNISA, UPSI, and USIP. We have successfully signed the MOA in December 2019, which I would say quite delayed. It is signed after 1 year the grant is approved. We have 3 phases in this project. The first phase involves individual semi-structured interview with healthcare providers and postnatal women who experience some maternal mental health disorders. Phase 2 involves series of focus group discussion to obtain expert feedback or opinion on the developed assessment tool. Phase 3 involves surveying to determine reliability and construct validity of the newly developed assessment tool. And we are now towards the end of the project, which is phase 3. Another project that we are working on is a project led by Dr. Shanti Wardaningsih from University Muhammadiyah Jakarta, UMY. This is a collaboration between UMY and IIUM. This project focuses on spouse and family perceptions of supporting maternal mental well-being across cultures in the context of Indonesia and Malaysia. So any challenges? Of course, yes. The first challenge, like everyone here can understand, financial challenges. In the first 2 projects that I presented just now, we need the agreement signed, then only money can be released to us. So the process of getting the agreement signed is not always easy. For the international grant, we have now started the project, although the money is not yet in IIUM, and therefore I could not get this project registered under RMC. It is quite tough, I would say, as you have been spending your own money and your own time, but it's not registered anywhere yet. The second is bureaucracy. As I mentioned just now, we had our research network initiated prior to the grant application. Through the network, we have built a strong relationship with clinicians, experts in different fields from the Ministry of Health Malaysia. We included them in the grant application. So we initially included Ministry of Health in the agreement. But upon series of discussion and meetings, it appears challenging to include them as researcher or partner. We have to go through many layers before our agreement can be read or can be considered by the Ministry of Health. So as I mentioned in my first point, we need the agreement signed so that we can get the money. With the focus of Ministry of Health on COVID-19, we are not so sure how long it will take if we included Ministry of Health as partner. The political issues, as I mentioned before, we included researchers from Myanmar, which is from University of Yangon and Mandalay as part of the team. But due to the political changes in Myanmar, we could not get into contact with researchers over there. We have been trying to contact them through various ways for quite a long period of time, but received no feedback. And finally, we decided not to include them in the agreement. For COVID-19, for the international grant, we face difficulties to have exchange visit as planned, although some budgets have been allocated for the traveling purpose. So we shift all meetings online. For the timeline, as I mentioned earlier, it took me more than a year to get MOA signed after the grant was approved for the second project. It took such a long period of time, and at some point, I think I don't want to proceed anymore. But one day, I received a phone call from RMC telling me to complete the MOA in 10 days. Otherwise, my grant will be withdrawn. So I did what I can within that 10 days. And Alhamdulillah, we managed to sign the MOA within the period given. So here are some potential collaborations project. This might be interest for some of you here. Perhaps we can work on the self-management apps for maternal mental health, digital toolkit for maternal mental health, machine learning models or algorithm for the prediction of perinatal depression and anxiety, and clinical advice by voice assistant using AI technology, which I have no idea, and how it can help to women or for women with postnatal depression. Right. Do I have any take-home message? Not many, just a few, I would say. Of course, networking is highly important in collaborative grant. You may need help from others to identify effective potential collaborators, although you can search also from the university's website. So seek help from people you know in IIUM or beyond. Contact the potential collaborators, build rapport with them. If you get rejected, then you need to find a new ones. I remember when I first started, I started with other university partners, but because of the limitations, challenges that we had to get the MOA signed, we end up with different university in our final MOA. So keep consistent. It is quite a long and lonely journey, but sometimes the hardest thing and the right thing are the same. Considering myself as a very young researcher when I first started, of course not in terms of age, I'm already old, but in terms of experience, I believe that it is quite hard in the beginning. So again, don't give up. But if you think that it is too hard for you not to give up, then maybe you just need to let them go. I think that's all from me. Thank you so much. I welcome any comments, suggestions, and happy to hear what do you think. Over to you, Dr. Widya. Thank you.
All right. Thank you so much, Dr. Siti Roshaidai. It is very interesting. I think that is very, very clear explanation to us as is not in that field. So I really understand that it's very important for us to know this, the maternal mental health, especially in this COVID-19 situation. I think it will give more impact for this newly mom, to give more actually burden, and also, in terms of psychological things. All right, we open for the discussion. Any question from the members through our speakers? We just directly ask that speakers, and then you can unmute your microphone if any question. All right, so I will start with myself. Is it okay, Dr. Roshaidai? Okay, because I'm quite interested just now when you are working with the Indonesian university. I just wonder, can you give us that how's actually the profile of this maternal mental health in Indonesia as an overall? Maybe you can get some pictures or how it looks like over there, or maybe we can compare with the Malaysia.
Thank you so much, Dr. Widya, for the very important questions. I learned a lot about the maternal mental health situation in Indonesia from my colleagues over there, which is Dr. Shanti from UMY and Dr. Henny from Brawijaya University. What I understood from the presentations from our meeting is that the stigma toward mental health is almost similar like what we had in Malaysia as well. They are quite struggle to identify or to screen the mother with any types of maternal mental health disorders as well. They are really at the beginning stage in terms of the publication. They don't have quite a lot in terms of maternal mental health issues. So now, as I mentioned in my presentation, we are in the phase of collecting data, so we identify, or we want to recruit the mothers who have experience of maternal mental health issues during their pregnancy and also after childbirth. And she admitted that she had difficulty in getting those participants because of the stigma that they had over there. So it's quite a challenging process in order to recruit the participants because of the stigma, as I mentioned just now. Yep.
All right. Thank you, Doctor. Any more questions from the members, from the audience? I believe we have many participants from nursing. Any more questions? Yes, Dr. Norafiza.
Yes,
Waalaikumsalam, Doctor. Yeah.
From CAS, Allied Health. Yes, you mentioned about the stigma just now. That is similar between Malaysians and also those in Indonesia. Can you explain a little bit more on the stigma, and especially what are the influences that those around the mothers have on these mothers, not only during pregnancy but also especially after childbirth? Thank you.
Thank you so much, Dr. Norafiza, for a very important question as well. Right, so talking about stigma, I think the stigma and mental health is a very long, well-known issues in the area of mental health. If I can zoom a little bit in the area of maternal mental health, normally the women don't want to be medicalized, taking medication, for example, they think that the medication might leading to the perceptions that they are weak mother, they are bad mother, something like that. And also about the treatment, the majority of the participants, for example, in my previous work on postnatal depression, they admitted that, or they have the perceptions that if I admit that I have this kind of maternal mental health issues, then people would say that I'm a weak. For example, if you are working as a profession, working as a nurse, for example, if you go for the psychiatric and seek for their opinion or the treatment, they would say that, oh, I'm weak and I cannot take care of my patients. That was being admitted by my patient when I interviewed them. And as a woman, as a mother, they would say that, okay, so now I cannot take care of my children, said another one. Another thing about this is regarding the traditional medication or the traditional treatment, I would say, the traditional treatment. So they think this is what we call supernatural, or something that related to the other makhluk. So they go for the treatment, shifa, and I always say that this treatment, this ruqyah, it is not strong. This is not strong at all. You can proceed, but at the same time, you need to go for the professional treatment as well, or professional help as well. That's among of the issues that I can remember just right now. I'm trying to figure out a few terms that they say. Okay, they say that the word of depression is similar to insane, being insane. So the level, even though we understand that in the area of mental health, there are some level of different types of mental health issues, and they make it quite similar, like all cases are schizophrenia cases. So they think that this one, when you admit that or go for the treatment, you think that, oh, you are insane or being mad, something like that. So not only among the women themselves, but also among the community members, among the family. Okay, so the same thing with the family. Most of the time, the husband, for example, trying to normalize the woman's feeling when the woman admitted that you know what, I have depression. And the husband said, okay, that's normal. That's how the woman after their childbirth feel. So they're trying to normalize and do not support the wife. Not all cases, of course, but a lack of support from the family, lack of support from the husband. That's what make the woman do not reveal their inner turmoil or their problems. So I think that's all. Hope that's answered your question, Dr. Narafiza.
Yes, very much. Thank you.
Okay. Any more questions from the other participants? Dr. Roshaidai, so when you said that you collaborate with the UK, so what is actually that? I mean, like, you know, the role of this UK institution that in terms of your research, Doctor.
All right. Actually, they are like a consultant for us. They initially they call for meetings, and they ask or they obtain input from these countries involved, the 4 countries involved. So we had a meeting and brainstorm what are the problems, what are the what we call mutual problems that all countries had, and then we put it in proposal. So the grant actually come from their country, which is Medical Research Council UK. So they are actually providing us the grant, and we become the collaborator in that grant, and they are the leader for that grant initially. But for each country, we have another leader. So yes, so basically the ideas come from us, but they put it into a proposal, and they help us a lot in terms of, especially in terms of the systematic review, in terms of getting the data, as well as advising for the certain types of the topic guide that we're going to use in the interview. And then the other thing, what the UK already established, that they have what we call patient's voice. So the patient's voice is like a website that the patients can refer in order to get support and get more information in terms of their care, including maternal mental health care. So in that website, they put all, they put some of the experience that come with the patient who had some experience of maternal mental health issue during their pregnancy or childbirth. And then other women can visit the website and get some information and support from that group. So actually, the project that we are working on is what we call comes from that idea. So we want to establish that kind of website in this region, combining that these 4 countries. So yeah.
All right, thank you, Doctor. Any more questions?
Just one small
Yes,
thing. Thank you very much, Doctor, for the nice presentation. Do you have any extension in future to extend to the other Asian country, or just you will be having these 4 countries in this group?
Yeah, thank you so much, Dr. Muzaffar, for the question. Yes, I think that will be a very brilliant idea if we extend that to the other countries more than beyond the Southeast Asian region. So I think that's a good idea. We're looking forward on that.
Yeah.
Maybe you have
I think
some
it would be
network
nice
over
to
there.
have like India, Pakistan, Bangladesh, and the Sri Lanka. Maybe you also expand to the other region in Asia Pacific gradually. That would be a very nice collaboration, and it will perhaps Oscar give you the the true reason the different society have, because all society setups are not the same. And obviously, like UK have 4 different setup than Malaysia or elsewhere in the Asian countries. So if we have the neighboring included, that would be a very good idea.
Yes, yes. Thank you so much for the idea. I know that Iran, the
Iran,
area
yeah.
of maternal mental health is quite established over there. So I mean, lots of papers that I read also comes from Pakistan and India. So yes, yeah, why not?
And
Yeah.
maternal problems are obviously more common in these countries compared to other countries.
All right. Yep. Brilliant idea. Thank you so much, Doctor.
Thank you.
Assalamualaikum,
Thank
Dr.
you, Prof.
Roshaidai.
Muzaffar. Any more questions? Yes, please. Yes, please,
Okay,
Dr.
Dr. Roshaidai, Dr. Harina here. I am so interested in your topic today. Okay, I just curious, is there any difference between, those mothers having depression from lower socioeconomic groups and from the higher socioeconomic groups? Are there any differences with this? And actually, what is the best mechanism to tackle these issues according to their needs? Do you have any idea? Because I believe that you have been handling this research or clinical studies more than 10 years. You might have observed a lot of these things happen in our community actually. Thank you.
Right. Thank you so much, Dr. Harina. I would say there is not so much different, but there is some difference in terms of their in terms of the factors that contributing to the maternal mental health disorders in those either developed or developing countries or high economic country and low or middle income countries. For example, in low middle income countries, we are talking more on the social support, more on the financial difficulties, for example, and in terms of the symptoms, what I can remember, it is not always because in the UK, for example, they go to the GP and say that I have depression, and I have this kind of symptoms. Tell to the doctor without the word that they use, I have depression straight away. But for the mother in Malaysia, for example, I'm talking about Malaysia, I cannot talk more on the other country, but in Malaysia, when the mother had depression, they go to the clinic. For example, we have maternal and child health clinics. When they, for example, after giving birth, they need to go for the postnatal checkup, and they will start the conversation of telling they are under depressed condition by telling the child's problem. For example, saying that my child crying so much, I don't know how to handle. That's one of the things that might indicate that they are having difficulties in terms of adapting with their new roles, for example, after giving birth. So they did not straight away using the word depression, although some patients may have the awareness. The highly educated patient, for example, they have the awareness about the maternal mental health issues and saying that what I have is depression, what I had is anxiety. But for certain mothers, they don't want to admit that they have the depression, or they don't know how to start, or maybe they think that the healthcare professional would not care enough. If let's say they say I have depression, they might think that okay, it is not their job. About taking care about the emotional problems, their job of their perceptions toward the healthcare providers maybe to take care of their jaundice baby, to take care of their blood pressure, to take care of their gestational diabetes, for example. So they start with the child issue, crying, how should I handle it? So yes, so many patients that are found like that. So yeah, the awareness, I think, in our country, low to middle income country, is not yet reached to the level what the developed country have, of course. I hope that's answered your question, Dr. Karina.
Yes, thank you.
Thank you, Dr. Karina. Any more questions from the members? Okay, I think shall we close, Dr. Roshaidai?
Yes, that's what I'm waiting for.
All right. Okay. Thank you so much, Dr. Roshaidai, for very interesting, I think, talk and discussion that we had today. And before I forgot that, actually, RMC already announced 2 days ago regarding the new grant from Yayasan Khazanah. And I think this is related with this mental health of our students in terms of the COVID-19. So if anyone interested to apply, so please do so that we are waiting for a lot of applicants. Yeah. All right. So thank you very much, Dr. Roshaidai. Again, a very nice knowledge that we gained today. Alhamdulillah. And before we adjourn, that I would like to close our webinar today with Tasbih Surah Kifayah and Surah Nas. All right, thank you very much, everyone, and Assalamualaikum warahmatullahi wabarakatuh. And don't forget to log in into attendance. Okay, thank
you very
you.
much.
Assalamualaikum, and see you to the next Fast Talk session.
Waalaikumsalam. Thank you.
Thank you.
Thank you.